It is indeed a great pleasure to be a part of MAMC Pediatric Surgery Update. Right? The topic for discussion today is bladder augmentation. So yes, I'm Dr. Arvind Sinha. I'm heading the Department of Pediatric Surgery at AIIMS Jodhpur. And as I said, we are talking about bladder augmentation. So what are the learning objectives of today's lecture? Is basically to understand what bladder augmentation is all about and what are the various indications. Why would you want to do bladder augmentations? We will also discuss the mechanics and the physics of augmentation. How do you create and augment? Various methods of bladder augmentations will be discussed. Then we will discuss not only the technical aspects, but also the problems and results after an augmentation has been done, because these children will require lifelong follow-up. And what are the various alternative techniques of augmentation that are available to a pediatric surgeon or a pediatric urologist? So if you look at it, the aim of bladder augmentation is to make something like a Mars, which is dry, small, inhospitable, into a large watery planet like Earth, right? So create a large reservoir with capacity to hold water at low pressure, right? Right. So bladder augmentation is also variously known as augmentation cystoplasty. It's basically a reconstructive surgery to increase the reservoir capacity of the bladder itself. So the aim of an augment will be to increase the reservoir capacity of the bladder and to decrease the reservoir pressure, right? So if you have to put it in one word, it is to create a safe bladder for the patient. So as I said, to hold more urine at a lower pressure, that's at the crux of what bladder augmentation is all about. It helps or simplifies the following management algorithm with regards to dealing with patient: augmentation of bladder capacity itself, prevention of upper tract damage. The meat, that is the kidney, has to be protected at all cost. Treatment of incontinence and creation of catheterizable conduit is also important. Now, what are the various indications for doing a bladder augmentation? So one of the commonest indications, especially in pediatric age group, is neurogenic bladder, that is spina bifida, tethered cord syndrome, spinal trauma, myelitis, and everything, right? The severe failed congenital anomalies is also one of the very important indications, especially bladder exstrophy, cloacal exstrophy, prune belly syndrome. Those are very important indications. Physical loss of bladder may be seen in, let's say, when we are managing malignancies, rhabdomyosarcomas, we may need to excise the bladder and then reconstruct the bladder itself. And then in adults especially, poorly or non-functional bladders may require, especially posterior urethral valves, radiation injuries, bilateral single system ectopic ureter where the bladder itself has not developed, detrusor instability, tuberculosis, and intestinal cystitis. Right. So factors which need to be assessed before considering the bladder augmentation. Right. The foremost thing that we need to consider is renal function. So long-term results have shown that these children have deteriorating renal function. Right. 20, 30, 50%, depending on the method used, of these patients will go into CRF or renal failure, right? So is it important to start off with renal functions which are appropriate, which are adequate for the child, right? Then second is vesico-ureteric reflux or urethral dilatation, right? If the patient has these VUR or urethral dilatation, then anti-reflux surgery must be considered along with augmentation. And if the patient has had previous urinary diversions, right? So these patients may have massively reduced bladder capacity. Then we need to also think about adequate regimen of bladder cycling to enlarge the bladder adequately for undiversion without need for augmentation cystoplasty. Whenever in doubt, undiversion without an augment needs to be considered, right? So wherever there is a previous urinary diversion has been done, think about doing an undiversion without an augment, right? Don't straight away jump to an augment, right? Because you may forget these patients, right? You may forget that you have done these bladder augmentation, but the bladder patients, children with bladder augmentation will keep coming. They will keep having problems. So many people consider bladder augmentation very a last resort surgery, right? So it should not be undertaken without much thought. Okay? Then you need to also consider about bowel function. The post-operative bowel function may be affected due to enterocystoplasty and all that. So if you're removing, so if there's already compromised bowel function, let's say radiation has been given or may be affected by enterocystoplasty, then the function may further deteriorate. And then the ability to catheterize, a lifelong commitment to clean intermittent catheterization is needed, depending on various indications, from 15 to 75% of patients. Now, what are the contraindications for doing a bladder augmentation? Foremost is patients who are unable or unwilling to perform a lifelong intermittent catheterization. Even though you may increase the bladder capacity, let's say, to 400, 500, 700 ml, but these patients still need to be catheterized every 3 hourly, right? So even though the bladder itself may have a capacity to hold urine for, let's say, half a day or a whole day, but you need to catheterize and empty that conduit, augment every 3 hours, right? So patients with inflammatory bowel disease, right? So any bowel pathology, right? That might be a contraindication. Patients with severe renal insufficiency is a contraindication for doing a bladder augmentation, because there is enough literature available that these patients undergo progressive renal deterioration. And poor surgical candidates and patients with a short life expectancy. Why subject these patients to a procedure when the expectancy itself is very less? So what are the various tissues that are used to augment a bladder? Intestine is a commonly used segment for augmenting the bladder. Ileum, colon, and sigmoid are all used for doing. That's the foremost and the most important segment that is used for bladder augmentation. Alternative that is available, gastrocystoplasty. There was a lot of buzz about gastrocystoplasty. That buzz seems to be going down because of the poorer results. Seromuscular enterocystoplasty, auto-augmentation, and uretrocystoplasty. Auto-augmentation, uretrocystoplasty especially, is very useful, very useful in selected cases, and if available, should definitely be jumped at. Then tissue engineered bladders, Anthony Atala et al. Are using tissue engineered bladder for augmenting the bladder, and they are possibly the way forward using unseeded or seeded technologies. So what are the reservoir requirements? One is, as I said, low pressure and a high capacity reservoir. Low pressure reservoir is less than 40 centimeter water, and a bowel will have peristalsis, right? So because we need to abolish the peristalsis to create a low pressure reservoir, and that is done by the method of detuberization of the bowel segment itself. And second is to create a high capacity reservoir, that is to allow for greater than 4 hourly emptying, right? The capacity should at least allow for a greater than 4 hourly emptying, but whenever we are talking about post-operative management, we say that you need to empty the bladder every 3 hours, like a normal preliminary bladder, even though it should have capacity of much higher, right? So that high capacity is achieved by reconfiguration of the bowel and the bowel length itself, right? What do you do with the native bladder? Clamshell bivalving is one of the very important methods which are available. Star modification that can create a very wide anastomosis, and a U-flap can be created so as to allow space in the posterior wall for reimplantation or mitrofenov and those kind of procedures. Now, coming on to use of ileum in the bladder itself, ileum is the most commonly used intestinal segment, and most of the advantages is that it's the most compliant and least contractile segment. It has a lower mucus production vis-a-vis the colonic segments, so it has lower mucus production and lower incidence of hyperchloremic acidosis. The disadvantage is diarrhea. Ileum absorbs a lot of water and can lead to diarrhea. B12 deficiency. B12 is typically absorbed in the terminal ileum, so may lead to B12. Hyperchloremic acidosis and other complications of ileocystoplasty. It has a poor muscular backing, therefore, reimplantation of the ureter or the mitrophenoff is almost impossible in ileocystoplasty, and cholelithiasis may also be possible. So terminal 20 centimeter, the ileum should be spared, and on the other hand, we should not go far out so as to take the jejunum, because jejunum conduit syndrome is also known, where it leads to severe metabolic derangement. So jejunum is never used for augmentation of the bladder, right? 20 to 40 centimeter ileum is taken and is cleared, detuberized, reconfigured, right? So it's reconfigured. Now, ileocystoplasty along with cystoplasty is also used, where the cecum is capacious, using a very small segment can create a large volume of reservoir, and it also gives the advantage that it allows reimplantation of the ureter. Appendix and ileum may be used for continent catheterizable stoma. Terminal ileum may be used as ureteral reemplacement. The disadvantage is because the IC junction is actually being used, diarrhea is troublesome. And vitamin B12, because you need to perforce use the terminal ileum, so B12 deficiency may be seen. High mucus pressures, high mucus production, and high pressure contractions may be seen in these ileocystoplasty and cystoplasty. Sigmoid colon was one of the preferred methods earlier, right? They would just attach the sigmoid colon to the bladder and expected that this be used as it will augment the bladder capacity. This was known as rat's tail augment, right? Now, advantages of redundant sigmoid colon is available, and it has a great for tunneling ureters. Disadvantage, again, mucus production is a major problem whenever you use the colon as a augment. High pressure coordinated contractions can also occur, and that may lead to an unsafe bladder, and hyperchloremic metabolic acidosis may be seen. Now, coming on to the results with regards to bladder capacity itself, basically all the various studies have shown that if you augment the bladder itself, there is an adequate increase in bladder capacity, right? So various studies have shown that there is an increase. How much to achieve will depend, how much bladder capacity to achieve will depend on the patient and the clinical condition of the patients. Now, coming on to the compliance itself, enterocystoplasty does not guarantee the bladder will be free from hyperreflexia, right? So even though we want the compliance to increase, but the pressure may still be prevalent in those bladder, and these high pressure may be seen in up to 23% of patients. Tonic phasic contractions may be seen in up to 77%, right? And this is, as I said, more common with the use of colon. Now, what are the other problems? Electrolyte imbalance or metabolic acidosis, another problem that occurs. That is, when urine is stored in the bowel for prolonged period, there's an increased absorption of urinary solute. So the dictum is the bowel will be bowel. It absorbs and it secretes, right? It continues to keep doing even if you attach the bowel to the bladder itself, right? So hyperchloremic metabolic acidosis is the problem that occurs with the use of ileum or colon for augmenting the bladder. So ammonium in the urine acts as a pretender. It pretends to be sodium in the sodium hydrogen exchanger and leads to chloride absorption and bicarbonate excretion. So that is the problem which leads to hyperchloremic metabolic acidosis, right? So what is the treatment of hypochloremic metabolic acidosis? It needs to be started very early in the management, right? Use of alkalizing agent, oral sodium bicarbonate, sodium salt solution, and other methods. Then blockers of chloride transport are used, right? Chlorpromazine and nicotinic acid may be used, and may require potassium replacement for hypokalemia if these patients are developing that. Right? Now, because of prolonged acidosis, these patients also undergo impaired bone growth and demineralization due to prolonged acidosis. So we need to follow these patients for a long period and to evaluate whether the calcium, phosphorus, these are normal or they are decreased. So bowel dysfunction and diarrhea may be seen in 10%, whereas it may be seen more commonly in spina bifida patient and may worsen bowel incontinence and control. And B12 deficiency, 35% may develop deficiency, especially terminal 15-20 centimeters the bowel utilize. And the more time that passes after an augment, more chance of vitamin B12 deficiency develop. The perforation is another complication that is rare in 5 to 10%, but can have serious life-threatening problems. Causes are bowel segment reconfiguration, high pressures, any traumatic catheterization, and ischemic necrosis. Now, mucus production is the problem which surgeons may not think that is too big of a problem, but the patient will almost always be most perturbed about mucus production, more with the use of, and this occurs more with the use of colon. Ileum has a lower risk, which further decreases villus atrophy over time. Stone formation may be seen 7 to 52%, and this is due to lithogenic property of mucus along with the bacteriuria that commonly occurs in these patients. Infection may also occur. A bacteria is the rule, and tumor may be seen with an increased risk of adenocarcinoma or transitional cell carcinoma, 4.5% in 32 years median duration, right? So if you follow these patients for a long time, you may see there is increased risk of tumor formation, especially in the leftover native bladder itself, right? And it is believed to be due to urinary nitrosamines. The other methods which are available, alternatives, are gastrocystoplasty, auto-augmentation, seromuscular enterocystoplasty, and ureterocystoplasty. Gastrocystoplasty is basically main advantage is it buffers the systemic acidosis and the donor tissue of choice in the presence of renal failure. However, various studies are coming in where 50% of babies with gastrocystoplasty progress to end-stage renal disease and develop malignancies if you had 10 to 20 years follow-up. So gastrocystoplasty, there is long-term results have not been too promising for gastrocystoplasty. These patients have decreased mucus production, decreased urinary tract infection, and good muscular backing, thus can allow for spontaneous voiding. However, disadvantages, as I said, immediate disadvantages will be hematuria dysuria syndrome, especially with sensate urethra. Peptic ulcer disease may be seen on the patch itself. Hypochloremic, hypokalemic metabolic alkalosis is the problem that occurs with gastrocystoplasty, and less compliant reservoir than ileum is seen. Ureterocystoplasty, if available, is possibly the tissue of choice to augment the bladder with, described by Mitchell, and it's one of the best tissues for augment. However, not every one is suitable for the ureterocystoplasty, and it requires a non-functional renal unit in the child, right? Or maybe even a functional renal unit with massively dilated and tortuous ureter for you to be able to augment the bladder, right? So ideal candidates for ureterocystoplasty are VURD syndrome with posterior urethral valve or end-stage renal failure on dialysis if you are considering for renal transplantation. Advantages is basically the urothelium, like to like, you're suturing like to like, native urothelium is sutured to urothelium of the bladder itself, right? No shrinkage of time. It's an extraperitoneal procedure and can be done, and spontaneous voiding can be achieved. Alternatives have been attempted. Tissue expanders, hydrostatic distension of ureter has been attempted to allow for enlargement of the ureter. Right? Results have shown a reasonable increase in bladder capacity and reduction in pressures. Auto augmentation is also being done, which is known as vasectomyotomy or vasectomyectomy. That is, the muscle of the bladder is removed, and it allows the mucosa to bulge out, creating an increase in capacity and low pressure. Right? The results have not been very promising, right? Seromuscular intracystoplasty is also being used, where demucosalized flap of colon or stomach have been put on top of the denuded mucosa of the bladder itself. Disadvantage is one of the very technically demanding procedure, more than even traditional augments. So advantages and disadvantages of various tissue, as I said, stomach decreases mucus, infection and stones, and better for short gut and acidosis and azotemia. Jejunum is not used because the electrolyte imbalances are extremely severe. Right? Ileum is the most common tissue used for the augment, along with large intestine if you require to reimplant the ureters, right? And ureter, whenever available, is probably the tissue of choice. Now, the last topic is what is basically tissue engineering. Tissue engineered bladder may be either a seeded technology or an unseeded technology. Right? Seeded technology uses harvested cells from the bladder which are grown, whereas unseeded technology use of tissue matrix graft, that is small intestinal submucosal graft, and then use it to grow the bladder itself. Right. So a recap: indications for neurogenic. We discussed the indications for doing an augment, that is neurogenic bladder and extrophy, are the commonest indications in pediatric age group. Detubularization reconfiguration need to be done to achieve a high capacity and low pressure reservoir. Ileum, colon and stomach, with ileum being the commonest segment used to augment. Stone, acidosis, growth retardation and tumors. They are the common problems that occurs in patients with bladder augmentation. Urothelium is available. Whenever it is available, is probably the tissue of choice, and experimental therapies are still coming up. Thank you. Have a nice evening.